Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Today we're going to discuss melanoma. I have the pleasure of being with Dr. Jeff Weber, Senior Member at the Moffitt Cancer Center in Tampa, Florida, and Director of its Comprehensive Melanoma Cancer Center. Dr. Weber happens to be my mentor since 2001, that's correct,
Yes.
When we were both at University of Southern California. Thank you for being here.
My pleasure.
Dr. Weber, what is melanoma?
Melanoma is a malignancy of your melanocytes,
Mm-hmm.
which are your pigment cells. And these are cells that can migrate anywhere through the body. And when they transform, they usually present as a dark lesion, usually in the skin. It could be in the eye, since we have pigment cells in the eye.
Mm-hmm.
It also can be on the mucous membranes, rarely, but almost all melanomas start in the skin,
Mm-hmm.
at the dermal epidermal junction, and have the capacity to metastasize and spread and cause the death of the host. One of the few skin tumors that will do that.
Mm-hmm. When should a patient seek consultation regarding a mole in the body?
Well, the classic is the ABCDs. It's the asymmetry, the border irregularity, the color being multivarigated, different colors,
Mm-hmm.
or having a diameter greater than 6 millimeters, which is about the size of a pencil eraser. Those are the sort of the warning signs, the
Mm-hmm.
classics.
I see. So if the color on a mole changes, that's a worrisome sign?
Yeah, if I had a mole on my body, and I do have quite a few, if it had changed color, I would certainly be wandering off to the dermatologist to consider a biopsy.
Okay.
No question.
What are some risk factors for melanoma?
Well, the classics are your pale complexion,
Mm-hmm.
those with blue eyes or green eyes, blonde or red hair, people with large numbers of nevi or normal freckles, say more than 100, people who tend to have those characteristics and live in a southern climate, such as we're in today,
Mm-hmm.
at 27 degrees latitude, and those who come from so-called atypical nevus families are at very high risk for melanoma.
Mm-hmm. I see. What does the thickness of the melanoma mean?
Well, the melanomas, as they grow, originally begin to spread laterally.
Mm-hmm.
And then they'll dive deep and grow vertically. So you have first what we call the horizontal growth phase, where they grow laterally. And then when they develop the capacity to spread, they grow vertically in the so-called vertical growth phase. And then they penetrate through the layers of the skin from the dermal epidermal junction between the junction of the outer and the inner skin.
Mm-hmm.
And that's where they encounter the lymphatics, they encounter the blood vessels, and that's what gives them the capacity, or gives them the ability to spread. So the thicker it is, the worse off it is. And if you look at the outcome in melanoma, if you graph millimeter for millimeter, and millimeter might not seem like a very big distance to you, but a couple of millimeters of melanoma is a lot of melanoma.
Mm-hmm.
For every millimeter, there's a significant decrement in the survival of the patient. So 8 millimeters is worse than 7 is worse than 6 is worse than 5, 4, 3, 2, and so on.
I see. What does the Clarke level indicate? That's a very important term in melanoma.
Well, Wallace Clarke is a famous, or was a famous, dermatopathologist who was at the University of Pennsylvania, trained many famous people. He's passed away some years, but he developed the initial notion that the outcome in melanoma depended on how far into the different layers of the skin the primary melanoma had invaded. So there's the papillary dermis, there's the deeper reticular dermis, and then there comes the subcutaneous tissue. It is a slightly archaic but still used system, and I still use it as a matter of fact, because the outcome in melanoma very directly varies with the actual thickness measured by the pathologist, the dermatopathologist, with a micrometer on the slide. As I told you, 8's worse than 7, 6, 5, 4, 3, 2, 1. There are only 5 levels, and there is not an exact correlation between the level and the outcome. There's a general correlation. So deeper level, always worse.
I see. What does it mean when the melanoma is ulcerated?
Ulceration implies that you've had a loss of the outer surface of the skin. It's basically eaten away, so to speak, by the tumor, and it usually simply reflects a more aggressive biology or behavior of the tumor. we know that ulceration is a very bad prognostic factor, and it actually worked its way into the staging system over the last 5 years.
I see. Is there a time when it would be appropriate for the patient to seek genetic counseling when they've been diagnosed with melanoma?
Well, it's an interesting question. About 5% of all melanoma patients have mutations in P16.
Mm-hmm.
That's a cell cycle control gene. They tend to be the patients who come from familial atypical nevus families. Not always. If someone is from such a family, and if it's been shown that they have a P16 mutation, I think it would be reasonable to have genetic counseling. The problem with doing genetic analyses in melanoma is there's no one mutation in a early melanoma, primary melanoma, that is a very useful prognostic factor.
Mm-hmm.
Because what are you going to do if you know that you have a P16 mutation in your primary? You're going to have intensive skin surveillance, but you would do that anyway if you had a melanoma. Mm-hmm. So it doesn't really affect the outcome much. So if it doesn't affect your management, as you and I were taught in medical school, why are you doing it? So if we had a series of mutations that we knew would impact on how we would handle the patient, and of course you'd want to know it, and you'd want to have a test, and you'd want to have genetic counseling. But usually, unless it's that rare P16 mutation, it's not necessary in melanoma.
I see. Let's say if someone does decide to have that test and the P16 is positive, does that have implications for the family members?
Well, certainly, because many of the P16 mutated patients come from a familial atypical nevus family, I think it would be useful for their family members, their immediate members, to have dermatologic screening. Mm-hmm. And once again, should that family member get a P16 test, well, that's okay, but how is it going to impact on how you live your life? Mm-hmm. I suppose if you could argue, it would keep that person out of the sun, have them wear a hat and sunscreen, and practice so-called safe sun practices. Well, that would be good. But those people should be doing that anyway if they have a primary relative with a history of melanoma, because most likely they're going to be at risk too.
I see. What does the mitotic rate mean? That's also very important to melanoma.
In the last couple of years, in the most recent staging criteria, now for the first time, the number of dividing cells, which is the number of mitoses in the primary, sort of per square millimeter, has been shown to be a poor prognostic factor. And again, it's like ulceration. It simply reflects a more aggressive biology and a more heightened tendency to metastasize. Mm-hmm. So if you have a thick melanoma, that's a high Clarke's level, has ulceration and a lot of mitoses, that's bad. Mm-hmm. That would be a patient with a poor expected outcome.
I see. Would you just please briefly go over the different subtypes of melanoma and what they mean for the patient?
Well, historically people have described superficial spreading melanoma, which is by far the most common type. It tends to present in the classic pattern, an irregular, flat, pigmented lesion. And it'll have a varied outcome. It'll vary by the depth. You can have the nodular melanomas, which, to be honest, you're characterizing them by their physical appearance. It's not an up-to-date molecular analysis, but many of those have gone into the vertical growth phase, have a poor outcome, will come on rapidly, often will grow in the absence of a pre-existing nevus, whereas the superficial spreading often arise in a pre-existing nevus. That's the classic pattern. So generally the nodulars would be regarded as a little more biologically aggressive. You can have acrolentigenous melanomas, which tend to occur on the palms and the soles, which account for the majority of melanomas in folks with darker complexions, African Americans, Hispanics, for example. And they can be subungual, under the nails of the fingers or the toes, and often they're diagnosed late because they either don't look like melanomas, or they look more like a wart, they don't have a lot of pigment, or they're on an area that you can't really see very well. So they often do poorly. And then there's the lentigo maligna melanoma, which is a particular type of melanoma. Lentigo, they often grow slowly. They have an indolent growth pattern. They're usually on the face in older people with a lot of sun damage. And they can be quite extensive and large, but they rarely cause the death of the patient. The nodulars are the bad actors. And you can go into some detail as to what genetic changes might be expected to occur. For example, in the acral lentiginous melanomas on the palms and the soles, you often have what we call a KIT, a c-KIT mutation, whereas that would be a little less common in a superficial spreading, unless it were a very sun damage related melanoma, in which case you might see it. BRAF mutations would be rarely seen in the acral lentiginous melanomas. Or the lentigos would be much more likely in a superficial spreading or a nodular. So as we begin to understand the genetic changes that accompany melanoma, we'll be able to do a better, more rigorous molecular characterization instead of just describing the melanoma by how it looks and how it grows, which is what we just discussed.
What about uveal melanomas, melanomas in the back of the eye? How does that happen?
Well, I wish I could answer that exact question. I don't think anybody knows. There may well be an association with UV exposure. They are, thankfully, a minority, perhaps 1 to 2,000 a year at the most, uveal melanomas. They have an unusual metastasis pattern. They tend to, 70% of them will go to the liver alone. So they have a classic pattern of metastasis to the liver. But again, anywhere there's pigment cells, you can have melanoma. We, of course, have pigment cells in the eye.
I see.
And we have them in the mucous membranes. There is pigment there, or are pigment cells. So you can have a nasopharyngeal, an oral, a vaginal, a urethral melanoma. And those are, of course, tough to see, often look like they're not melanoma, often have a diffuse pigmented appearance. And there's probably a somewhat poorer outcome for mucosal melanomas than for melanoma in the skin.
I see. Patients always want to know what stage they are. How do you stage melanomas?
Well, most melanomas, of course, are in the skin, 90-some odd %. So the predominant staging is stage 1 and stage 2 is in the skin, depending on how deep it is. And A and B would refer to ulcerated or not ulcerated and ulcerated. And the deeper in millimeters you get, the more likely it is that you have a higher substage within 1 and 2. Stage 3 is local, regional, and lymph nodal metastases, that is in the region of the tumor. And stage 4 is distant metastatic disease. And again, within each stage there's a substage. For example, within stage 4 there's M1, A, B, and C. A is in the skin and nodal tissue only with the normal LDH, which is a rough tumor marker. B is in the lungs with the normal LDH, with or without being in the skin or the lymph nodes. And M1C is any visceral disease, liver, bone, brain, or an elevated LDH, which again is lactate dehydrogenase, and it's a rough indicator of tumor burden.
I see. Well, let's just take a step back. Assuming a patient's had a biopsy of a lymph node or a mole that has come back positive for melanoma, what happens next for that patient?
Well, if I had a diagnosis of melanoma made by my dermatologist, which is where most of them are made, I would want to be sent to a referral center to be seen by a surgeon experienced in the performance of melanoma surgery. That person's going to need a wide and deep excision. In this country, the standard of care would be to do a sentinel lymph node biopsy. They'll need a full exam, a history. They'll need to have their risks of surgery assessed, of course. They'll need a chest x-ray and some labs. And depending on how thick the melanoma is, the substage, and whether the tumor actually got into the lymph nodes, they might get some extra scanning, some radiologic procedures to prove that there's no other spread of the melanoma. You obviously hope to have a thin melanoma, not a thick one. You hope that your sentinel lymph node biopsy, which is where they inject blue dye that's slightly radioactive, around the primary tumor before they remove the extra tissue to free you of local disease. You have that dye track quickly to the draining lymph nodes, and you use a little Geiger counter, looks like a little pancake meter, to detect where the counts in the dye go. So you count the counts with the Geiger counter, and you look with your eyes to see where the blue goes. And within 30 minutes, it'll track to the draining lymph nodes. That first node is the sentinel node. The surgeon then removes it. Often you can see the blue through the skin. But you go where the radioactivity is, you remove it, and if it's negative, that's good. If it's a positive lymph node, in this country, the standard of care generally would be to have a completion lymphadenectomy. That is, you would take out all the rest of the draining lymph nodes in that area, in the neck, under the arms, in the groin, behind the knee, etc.
So let's say if a lymph node is positive, would you recommend any further scans after that?
If you have a positive lymph node, at least in your sentinel node biopsy, and even perhaps positive lymph nodes in your completion lymphadenectomy, I generally would get a CAT scan of the involved part of the body. Upper body, CAT scan of the chest, lower body, abdomen and pelvis. Unless there were a lot of nodes positive, I probably wouldn't get a MRI of the brain. Nor would I get full CAT scans unless the risk was well over 50%.
I see. So let's assume that the melanoma has been resected, but the lymph nodes are positive, and the scans don't show cancer anywhere else in the body. Is there any treatment you would recommend after that?
Well, there is an FDA-approved adjuvant therapy for melanoma if you have positive lymph nodes, and that's high-dose alpha interferon. It's a year-long regimen. It has been shown to prolong the relapse-free survival, that is the time to return of your tumor. It has a small effect on survival when we put lots of patients together in what we call a meta-analysis of thousands of patients treated with this drug. That small difference is only about 2 or 3%, and that's a modest benefit in survival, balanced against a significant amount of side effects in virtually all patients who get it. So it's a juggling act, and it's a scenario where we present to the patient the options, and they'll make the decision whether they want to do it or not. Depending on the institution, anywhere between a third and 2/3 of patients eligible to go on interferon will go on that drug. There are multiple clinical trials in stage 3 lymph nodal melanoma that's been surgically removed or resected. We have one such trial now that's a national trial, the so-called intergroup trial. It's a trial of interferon as the reference arm versus ipilimumab, a recently approved immunotherapy for melanoma. And that is a legitimate trial to do, and we put patients on that trial. We also have our own institutional trials. These are investigator-initiated trials where we test new immunotherapies in those who have high risk resected stage 3 melanoma, those with multiple positive lymph nodes.
I see. So exactly what is interferon? How does it work, and what are the side effects?
Well, interferon is a molecule discovered, my goodness, some 40 some odd years ago. That was discovered because it interfered with viral replication. That's why it was called interferon. It turns out that there's a whole family of interferons. There are interferons alpha, beta, and gamma. And there are a whole series of glycoproteins that have as their major function decreasing the ability of a virus to replicate. Turns out that some of the interferons, chiefly the type 1 interferons, have anti-tumor activity in kidney cancer, in melanoma, which is found in the 80s, in some of the hematologic malignancies, hairy cell leukemia. So it was tested back in the mid-1980s as an adjuvant treatment, meaning it was added after surgery to treatment for stage 3 melanoma. And in the first study, it prolonged survival compared to no treatment at all. And how it works is actually a bit of a mystery. A lot of patients will relapse after stopping it, implying that it's an anti-proliferative agent that works only as long as you give it. But we know it's an immune stimulant. In reality, it probably has a combination of features that render it a potentially useful drug in melanoma. It's given every day in the veins, 5 days on, 2 days off, 5 days on, 2 days off, for 4 weeks in a row. And then you self-inject Monday, Wednesday, Friday for another 11 months for a total duration of a year. It's a complicated regimen. In August was approved a so-called pegylated or PEG interferon. That's a slow-release interferon. And that's only given as a shot once a week, but it's given over anywhere between 2 and 5 years. It's given over a long duration. and in some ways better tolerated than interferon, although in others probably has the same kinds of side effects.
Mm-hmm. So the first month that's intravenous, what side effects should the patient expect?
That first month, I would say, the major issues are fevers, chills, and fatigue, which would be the most common side effects of interferon. It is rare to see severe liver toxicity, low platelets, although I've seen that after only a couple of doses. Anemia, that takes a while to build up. But the biggie is the patients get fatigue and they have these flu-like symptoms, so it just makes you feel like you've got a bad cold.
I see.
And it's particularly significant in that first month, and then it tails off because your dose drops by 70% once you pass the first month. Nonetheless, this is a drug with some significant side effects where I think the patients obviously pay a price. And we'll put people on different types of interferon, or put them on interferon, balancing those risks against the potential benefit. And I think that's how it should be given.
I see.
It's also used for resected stage 4 melanoma, where it's never been truly tested, although it's the only approved drug that's used in that way. We, of course, have many trials for resected stage 4 melanomas. It's one of the specialties of the institution. Certainly one of my interests, as you may remember. But interferon gets a fair bit of use in the United States. High-dose interferon, as I described it, is almost never used in Australia or Canada. In Europe, they use a different dose of interferon. So there's a huge variation in practice patterns and the use of interferon around the world.
What about some association with depression? What is that?
Well, certainly interferon can have central nervous system side effects. And one of those side effects is worsening pre-existing depression, or in someone with a tendency thereof to bring on severe depression. And I've certainly had to stop patients being treated with interferon because of the depression.
I see.
So it's certainly a known and major significant side effect.
Can patients work while receiving this treatment?
I have certainly had plenty of patients who went to work. I have had the spectrum from a guy who was an accountant who went to work every day and had no side effects, to people who could barely get out of bed in the morning and drag themselves and eat breakfast. I would say most of the young folks still working will continue to work, although, to tell you the truth, I tell them that they'll feel like a V8 firing on 5 or 6 cylinders. The fatigue factor is real, and you will not be your full self, but almost everyone who wants to work can.
I see. What about sexual relations with a partner? Is that possible while receiving treatment?
It is, but I'll tell you, when you're getting interferon, that's pretty much the farthest thing from your mind. I haven't heard too many patients telling me that they're worried about sex a lot. They just come home, eat their dinner, and crash, and often they'll sleep for 10 hours a night.
I see.
That's the pattern.
What about fertility preservation in patients receiving interferon? Would you recommend that or no?
Well, I think you have to, because there are no data about reproduction during the time that people are on interferon, and we tell them as part of a trial all the time that they should not get pregnant and they should practice significant birth control, because you do not want to get pregnant while on a drug that might have serious negative effects on the fetus.
Is it necessary for men to freeze their sperm? Will it have consequences later on or no?
Well, it is certainly an option for any young male with fertility, with an ambition to have further children or to have children. Anyone starting chemo who's young, anyone starting interferon or an investigational trial for whatever stage of disease, I think has to consider it.
So you do recommend consultation with
Oh yeah, absolutely.
I see, very nice. I see.
We just are starting a young guy today on biochemotherapy. Complicated regimen who has stage 4 disease. He's only, oh my goodness, he's like 21 years old. So, sperm banking was an issue.
I see. What about menstruation in women? Does that stop when they receive treatment?
Variable. With chemotherapy, certainly it absolutely does. It's very variable with interferon. I would say more likely than not, yes, it would interfere with menses. Although I think that would be a reversible phenomenon, unlike in some chemotherapy regimens.
So what do you tell your patients regarding the odds of cure or the chances of recurrence if it's lymph node positive versus lymph node negative disease?
Well, if it's lymph node negative, as long as it's not a really thick melanoma with ulceration and a lot of mitoses, I tell them that they're in great shape, and more likely than not, a lot more likely than not, they're going to be cured by surgery alone. If they have positive lymph nodes or have resected stage 4 disease, I'll be very honest with them, and I'll tell them, they'll always ask, well, doc, how long am I going to live? And I say, well, I don't know how long you're going to live. Nobody does. Only God knows. But I can tell you, if we had 100 patients like you, the median survival of those 100 would be X years. That is, 50 would be alive and 50 would be dead at a certain time. And that's, I think, the best way to express it. It's a statistical assessment. It's not looking at an individual and saying, you are going to live 3 years and you over there are going to live 6 years. You never know. You can't read the future, but you can say for all patients with stage 3 melanoma, with at least one palpable positive lymph node, the median survival is, meaning half alive and half dead at 36 months. That's the kind of thing you can say.
I see. What do you suggest to the spouses or children? I know going through interferon therapy is very difficult. What do you say to the family members?
They're going to need a lot of support, especially if it's a young woman who has kids at home. That's a tough one. I can't imagine being a working young mother on interferon and having kids at home and going to work. That's over the top. I couldn't see doing that. But you have to make the spouse realize that they're going to be pretty wiped out at the end of the day. And at the end of the year, the good news is eventually it goes away. It'll take 2 to 3 months to get better. But 2 to 3 months after finishing interferon, almost all people go essentially back to the way they were before they started.
I see. Are there any support groups that you recommend your patients to join?
Well, we have a support group here for our patients, and that's one that we have them join. A lot of people don't want to do that. I think it's a totally reasonable thing to do.
I see. Well, thank you so much. Thank you for watching. We hope this has been educational for you.